Imagine a promising young pitcher, maybe someone you've seen in your community or even treated, excelling, arm a blur, future looking bright. Then, almost imperceptibly, a bit of pain starts in their throwing shoulder. Not a dramatic injury, but this persistent ache. It slowly chips away at their performance, their speed drops, and eventually they're sidelined. What might seem like growing pains or just overuse could actually be something quite specific, particularly given the stress on a developing body. Welcome to the deep dive. Today, we're really getting into a condition called Little League Shoulder, or LLS. It's not just any throwing pain, it's a specific overuse injury, and for you, as healthcare professionals, understanding it is crucial. Not just for treatment, but really for safeguarding these young athletes' futures. Our mission today, aimed at you, our mid senior medical professional listeners, is to unpack the complexities of LLS. We'll look at its presentation, how management has evolved, and the vital role of evidence based practice. We'll explore what we know and, importantly, what we still don't fully know. Guiding us through this is Prof. Imam. Welcome.
Thank you. It's a pleasure. This is, certainly a topic that warrants close attention, especially with the pressures on young athletes today.
Okay, so to start, let's really pin down what Little League Shoulder actually is. We often hear it loosely described as throwing shoulder pain, but that doesn't quite cut it medically, does it?
No, it doesn't. That distinction is vital. LLS isn't just general pain. It's a very specific overuse injury found only in skeletally immature athletes. Medically, the term is proximal humeral epiphysiolysis, or perhaps more clearly, a humeral head growth plate injury.
Right, the growth plate.
Exactly. The problem lies specifically with the physis, that's the cartilaginous growth plate right at the top of the humerus where the arm bone meets the shoulder. That's the site of the stress injury.
And why is that specific area so vulnerable in young people?
Well, the physis in a growing individual is fundamentally different from mature bone. It's mostly cartilage, so it's softer, inherently weaker, and much more susceptible to certain stresses. Plus, it's incredibly active. This particular growth plate, the proximal humeral physis, is responsible for about 80% of the humerus's final length. Massive growth happens there.
80%, wow.
Yes, it's significant.
Yeah.
And this plate doesn't usually fully fuse or ossify into solid bone until somewhere between 16 and 20 years old. So for all those crucial developmental years, it's a potential weak link in the chain for an overhead athlete. When we look at imaging, the classic sign on an X-ray is widening of this growth plate.
Compared to the other side.
Precisely compared to the non-dominant shoulder. This widening is typically classified as a Salter-Harris type. An injury is separation through the growth plate itself, usually without the bone shifting significantly out of place.
Okay, that makes sense. So given that vulnerability, let's unpack the why. Why does this specific part of the shoulder get injured so often in young throwers? What's the core etiology?
At its heart, LLS is truly an overuse injury. It's driven by repetitive microtrauma. Think about the act of throwing, the sheer volume, the repetition, and particularly the cumulative rotary torque, the twisting force experienced by the throwing arm. That's the primary culprit.
And the cartilage is particularly susceptible to that twisting.
Exactly. The cartilaginous physis handles torsional forces much less effectively than mature bone does. It's more vulnerable to twisting than it is to direct pulling or tension. So each throw, especially fast ones, puts significant rotational stress on this delicate growing structure. Over time, without enough rest, this leads to inflammation, tiny bits of damage, microfractures within that cartilage.
And the amount of throwing seems key.
Very much so. Studies consistently link the sheer number of pitches thrown the volume directly to the pathophysiology of LLS. It's not usually one single bad throw. It's the accumulation over weeks and months that overwhelms the physicist's capacity to repair itself.
So volume and rotational stress are central, but I imagine it's rarely just that. Are there other factors that increase the risk or make an athlete more susceptible? It feels like it must be multifaceted.
Oh, absolutely. While that cumulative load is the foundation, several other factors play a really significant role. They can either predispose someone or exacerbate the problem. Firstly, and this is a big one, poor throwing mechanics. Improper technique puts vastly more stress on the shoulder and arm.
Because the force isn't distributed correctly through the body.
Precisely. If the kinetic chain legs, core, trunk rotation isn't working efficiently, or if there are weaknesses elsewhere that the athlete compensates for, the shoulder, and specifically that vulnerable growth plate, ends up taking far too much of the strain. This is why understanding good biomechanics is crucial, not just for coaches, but for us as medical professionals advising them and the parents. It's injury prevention as much as performance enhancement.
Okay, mechanics. What else?
Second, insufficient rest and recovery. This is incredibly common, unfortunately. Young athletes, coaches, even parents can push too hard, chasing improvement or wins. But inadequate rest between throwing sessions, between seasons, prevents that microtrauma from healing. The damage just accumulates. The physicist never gets a chance to catch up and repair properly.
That cycle of stress without recovery.
Exactly. Then third, there's the obvious factor of age and development. The risk is highest when those growth plates are open and most active. A 12-year-old's physis is structurally different and responds differently to stress than an 18-year-old's fused bone. So vigilance is key in that younger age group, looking for early signs of pain or fatigue.
And
Finally, the trend towards early sports specialization. We see more and more kids playing just one sport, like baseball, year-round.
no real off-season.
Correct. That constant repetitive stress, using the same movement patterns over and over, doesn't allow for adequate recovery. It also means those specific structures, like the proximal humeral physis, are under continuous load without the variation that playing multiple sports might provide.
Okay, so let's shift to the clinical encounter. A young athlete walks into your clinic. Maybe they've been sent by a concerned coach or parent. What's the typical story you hear? What are the presenting symptoms that should make you think of LLS?
The main complaint, the chief complaint, is pretty consistent. It's pain, specifically localized to the dominant proximal humerus, the upper arm near the shoulder. And crucially, it's pain that's brought on or made worse by throwing or sometimes other overhead actions like swinging a racket.
Is the onset usually sudden or gradual?
It can be either, actually.
Hmm.
Sometimes they might recall a specific throw where it started sharply, but more often it's insidious. It creeps up gradually over time. The duration of symptoms before they actually seek help can vary hugely, too. We see everything from just a couple of weeks to sometimes, surprisingly, up to a year of nagging pain.
A year.
Yes. Sometimes they try to push through it. The pain often gets worse as they throw more pitches, or if they try to throw harder faster. They might describe it as a deep ache that lingers after they stop throwing.
Are there other symptoms besides the pain itself?
Yes, definitely. They might report persistent soreness for a day or two after throwing. You might find localized tenderness if you press on the area, sometimes even a little bit of swelling, though that's less common. A very common report, and often what triggers the visit, is a noticeable decrease in their performance. They can't throw as fast, or their accuracy suffers.
That performance drop is a red flag.
It really is. And as it progresses, the pain might start to affect other things, other overhead sports like swimming, or even just lifting a bag or carrying something heavy. They might also mention stiffness, a feeling that the arm is hard to loosen up.
So you've got this history, the story of activity-related upper arm pain and maybe performance decline. What are you specifically looking for during the physical examination? What findings really point towards LLS?
The physical exam is key for confirming suspicions. The most consistent finding, reported in about 2/3 of cases in a large review, is tenderness to palpation. So carefully feeling along the anterolateral or posterolateral aspect of the proximal humerus, the front side or back side of the upper arm bone near the shoulder joint. If it's tender right over that growth plate area combined with a history, that's a strong indicator.
Okay, localized tenderness. What about movement?
Range of motion is the next thing. Nearly half of these patients might have pain during certain movements or a noticeably altered range compared to their non-throwing arm. Specifically, we look for something called glenohumeral internal rotation deficit, or GRR. That's been reported in about 16% of cases. Basically, they can't rotate their throwing arm inwards as far as the other arm.
GR.
You might also find pain or weakness when you ask them to resist you as you try to rotate their arm outwards, resisted external rotation. That shows up in about 10% of cases. Less commonly, you might find weakness with internal rotation or lifting the arm out to the side, abduction. It's worth noting, though, that standard tests for shoulder instability or impingement aren't typically positive or routinely needed for diagnosing LLS itself. The main issue here is the stress on the growth plate, not usually ligament laxity or rotator cuff impingement, although those can sometimes coexist, particularly later on.
That makes sense, focusing on the likely site of injury. So history and exam give strong clues. How do we definitively confirm the diagnosis? What role does imaging play, and what are we looking for?
Imaging is crucial here, and plain radiographs, standard x-rays, are usually the first and often the only imaging needed. We typically get anteroposterior, or AP, views of both shoulders, critically both the affected and the unaffected side, and we often get them in both internal and external rotation.
The comparison is key then.
Absolutely vital, because the classic radiographic finding seen in nearly 99% of diagnosed LLS cases in that systematic review
is widening of the proximal humeral physis in the throwing arm compared to the non-dominant side. Having the normal side for comparison helps confirm that the widening you're seeing is indeed abnormal and not just their baseline anatomy.
So widening of the growth plate is the main thing. Are there other, perhaps more subtle signs on X-ray?
Yes, sometimes you see other changes, though they're less frequent. You might see some fragmentation or perhaps areas of demineralization bone looking less dense or sclerosis where the bone looks denser right next to the growth plate in the metaphysis. Very rarely you could see an actual Salter-Harris type 2 fracture, which involves growth plate and a small chip of the metaphysis, or even things like tiny superiosteal cysts near where the biceps tendon attaches. But widening is the hallmark.
What about more advanced imaging like CT or MRI? When would you use those?
They're generally reserved for specific situations, not usually needed for the initial diagnosis if the X-rays and clinical picture match up. A CT scan can also show the physial widening very clearly. It's particularly good for getting a detailed three-dimensional look at humeral retroversion, the amount the top of the humerus is twisted backwards relative to the elbow. That can sometimes be relevant.
We'll come back to retroversion and MRI.
MRI can also confirm the diagnosis, perhaps if the X-rays are a bit equivocal, or if you suspect associated soft tissue injuries. MRI is excellent for showing the effects of stress on the bone and surrounding tissues. You might see bone marrow edema, basically fluid, or even slight lifting of that periosteum, all signs of the underlying stress reaction.
Okay. Now, you mentioned earlier that sometimes physical widening can be seen in athletes without symptoms. How does that fit into the diagnostic picture? Is the widening always pathological?
That's a really important clinical point. There have been reports finding incidental, asymptomatic physial widening in some young overhead athletes. So yes, widening on its own without the clinical context isn't automatically LLS. However, the evidence from the systematic review strongly suggests that for a formal diagnosis of Little League shoulder, you really need both things. The characteristic symptoms, that activity-related proximal humeral pain, and the positive radiographic findings, primarily that physial widening. The combination is key, that 99% figure link symptoms and radiographic changes.
That's a crucial clarification for clinical practice. You mentioned humeral retroversion again and CT being good for assessing it. Can you elaborate on the connection between LLS and humeral retroversion? Is it a risk factor or does it develop because of the throwing?
It's a fascinating area and frankly one where the evidence is still a bit murky regarding cause and effect. Several studies, typically using CT scans, have looked at humeral retroversion in athletes with LLS. They consistently find that the degree of retroversion, that backward twist of the humeral head, is significantly greater on the dominant throwing side compared to the non-dominant side.
By how much, typically?
The difference can be quite substantial. One study reported an average difference of about 20 degrees. Another case report found over 27 degrees more retroversion on the throwing side. So the observation is definitely there. The big question is, why? Is this increased retroversion something an athlete is born with, an anatomical variation that perhaps alters their throwing mechanics and predisposes them to LLS? Or is it an adaptive change? Does the repetitive high-volume throwing during skeletal growth actually cause the bone to remodel and develop increased retroversion over time? Or perhaps even a mix of both?
And we don't have a clear answer.
Not definitively, no. Because most of the studies looking at this are retrospective. They measure retroversion after the athlete already has LLS. It's very difficult to disentangle cause from effect without prospective studies that track athletes over time before they develop symptoms. What we can say is that these rotational differences in the shoulder, including increased retroversion and the GRD we mentioned earlier, are frequently associated with LLS and other throwing-related issues in young pitchers. Their exact role, whether cause or consequence, is still an active area of investigation.
Thinking about treatment, the approach for these sorts of growth plate issues in young athletes wasn't always what it is today. Can you walk us through how the management of Little League shoulder has evolved over time? Things used to be quite different, didn't they?
Oh, drastically different. If you look back at the literature, particularly before the late 1990s, the management strategies were often, well, quite severe from the athlete's perspective. It often involved very prolonged periods of complete rest from throwing. Sometimes, recommendations were for complete cessation of pitching indefinitely, or at least until the growth plates were seen to be fully closed on X-rays.
Which could be years later.
Exactly. Imagine telling a 12 or 13-year-old they might not be able to pitch again until they're 17 or 18, based solely on an X-ray finding. Some early advice literally stipulated total rest from throwing until radiographic physio closure. Others were just told to switch positions permanently, give up pitching.
That must have been devastating for many young athletes. What changed?
A really significant shift happened around 1998. It was heavily influenced by a key case series published by Carson and Gasser. Their crucial insight, their postulation, was that the Salter-Harris type eye fracture, typical of LLS, that separation through the growth plate actually heals clinically much faster than it looks healed on an X-ray. The radiographic changes, the widening, can persist long after the athlete feels better and the physis is stable enough for activity.
So symptoms resolve before the X-ray looks completely normal.
Precisely. This was groundbreaking because it allowed for a shift away from purely X-ray-driven decisions towards a more symptom-guided approach. Based on their findings, they suggested that athletes could likely resume throwing once their symptoms had fully subsided, which typically occurred after about 3 months of rest in their cohort. And their results were excellent. They reported a 91% return to sport rate, which was a huge step forward.
That really changed the game then, moving from X-ray watching to listening to the patient.
It really did. It marked a fundamental shift in philosophy.
So, bringing us up to date, what are the current recommendations for managing LLS? How long is rest typically advised now, and what guides the return?
Current recommendations generally favor shorter, more tailored rest periods compared to the past. The duration still varies depending on the severity, symptom duration, and individual response, but it might range anywhere from 1 month up to maybe a year in very persistent cases. However, a period of around 4 months of complete abstinence from throwing is quite a common recommendation you'll see now.
4 months, okay.
But the absolute key principle now is that the return to sport, RTS decision, is driven primarily by symptom resolution and clinical assessment of healing, not just waiting for the X-ray to look perfectly normal. Field closure on radiographs is no longer the main gatekeeper, as we know it lags behind clinical recovery.
And what about other activities during the rest period?
That's another important change. Newer advice strongly encourages athletes to continue with other forms of physical activity in sports, as long as they don't involve stressful overhead arm movements. Maintaining cardiovascular fitness and general conditioning is important. And importantly, the advice is generally not to change positions indefinitely anymore. The goal is rehabilitation to allow a safe return to their chosen position, if possible.
That sounds much more holistic and athlete-centered. So beyond just stopping throwing, what are the core treatment modalities used during recovery and rehabilitation?
Activity modification, stopping the offending activity. Throwing remains the absolute cornerstone. That period of rest, typically around that 4-month mark we discussed, is non-negotiable initially.
Okay, rest first, then what?
Then formal physical therapy, PT, is strongly recommended, especially if, during the initial assessment, you've documented limitations like restricted range of motion or that glenohumeral internal rotation deficit, GIRD. The focus of PT is really comprehensive. It's about restoring full pain-free range of motion in the shoulder. It's about improving strength, not just of the rotator cuff, but also the crucial scapular stabilizer muscles around the shoulder blade, and enhancing overall flexibility of the shoulder girdle.
What kind of exercises are typically involved?
Initially, it might be more gentle range of motion work. Then, as pain settles, typically around 3 to 6 weeks post-injury, we introduce strengthening. This usually involves low-weight, high-repetition exercises targeting the rotator cuff and those scapular muscles. We're building endurance and control, not bulk strength initially. PT also addresses the bigger picture, strengthening the core and lower body, ensuring the entire kinetic chain is working efficiently to take load off the shoulder when they eventually return to throwing.
Right, addressing those potential contributing factors like poor mechanics or weakness elsewhere.
Exactly, it's a whole body approach.
Okay, so they've rested, they've done their PT, strength and motion are good, pain is gone. Now comes the really tricky part, getting back to throwing safely. How should that return to throwing phase be managed? It can't just be go for it, surely.
Absolutely not. The return to throwing RTT protocol is perhaps the most critical phase, and it needs to be managed incredibly carefully. It must be a customized, highly graduated program. You start very slow, very controlled, short distance throws, low velocity, low volume, maybe just tossing a ball gently. Then, based entirely on how the athlete responds crucially, remaining pain-free, you gradually, incrementally increase the throwing intensity, the frequency of throwing sessions, the number of throws per session, and the distance.
Step by step.
Precisely. It's a very structured progression. And the golden rule is, if any of the original soreness or symptoms reappear at any stage, you immediately back off. You either decrease the activity level back to the last pain-free step, or you maintain the current level without increasing until those symptoms fully resolve again before trying to progress further.
Patience is key.
Patience and very open communication between the athlete, therapist, coach, and parents. It's an iterative process.
But finding reliable, specific protocols for this, is that straightforward?
Ah, now you've hit upon a major gap. While RQT protocols are universally recommended and considered essential, there's a surprising lack of specific, evidence-based, graduated protocols published in the literature that have been rigorously studied. The systematic review we've been discussing found only one case report that actually described a specific, regimented throwing program used post-LLS, and another that mentioned incorporating a coaching strategy to improve mechanics during the return.
Really? Only 1 or 2 examples in the published research.
In terms of detailed, validated protocols, yes, it's a significant deficiency. We recommend these graduated programs constantly in clinical practice, but we're often relying on general principles, expert consensus, or protocols adapted from other injuries rather than programs specifically tested and validated for LLS recovery in young throwers. That's a huge area needing future research.
That is surprising given how crucial that phase is. Are there any other treatment aspects to mention? Medications, surgery.
Medications like nonsteroidal anti-inflammatories, NSAIDs, might have a role for short-term relief of acute pain right at the beginning, but they certainly aren't a long-term solution and don't address the underlying mechanical issue. They just mask the pain. And surgery. It's almost never indicated for Little League shoulder. The condition is overwhelmingly managed successfully with conservative treatment. The rest, the PT, the graduated return. Surgery is exceptionally rare. #tag 5E. Outcomes, complications, and the road ahead.
It's really positive to hear how effective conservative management generally is. Let's talk about outcomes. What can athletes and their families typically expect regarding symptom resolution and, the big question for them, returning to their sport?
The outcomes are, generally speaking, very encouraging, which is great news. Looking at the pooled data from that systematic review involving 261 participants who had adequate follow-up, essentially 100% of them experience a complete resolution of their symptoms.
100% resolution, that's fantastic.
It is. Now, the time it took to reach full symptom resolution did vary. The average time reported across different studies ranged from about 2 months up to around 7.7 months. So while everyone got better, the timeline can differ individually.
And what about getting back to playing?
Return to play rates are also very high. Overall, 94% of the participants with available data managed to return to playing some form of sport. And perhaps even more importantly, 92.5% of those athletes, that was 123 out of 133 where it was specifically reported, were able to return to their pre-injury level of sport participation.
Back to their original level, that's the goal, isn't it?
That's absolutely the goal. Again, the time frame for this return varied anywhere from 2 months to, in some cases, up to 2 years. But the fact that over 90% get back to where they were before the injury really speaks volumes about the effectiveness of current management when it's followed diligently.
That's incredibly reassuring for clinicians and families dealing with this. But medicine is rarely straightforward. What about recurrence? Does the pain come back? And are there potential complications, either short or long-term, that we need to be aware of?
That's right. We need to consider the potential downsides, too. While recovery is the norm, recurrence of symptoms after returning to sport is definitely something that happens and needs to be discussed. The systematic review found an overall recurrence rate of about 18.7%. So nearly 1 in 5 experience pain coming back after they resume throwing.
Almost 20%.
Yes. However, it's important to note there was huge variation in reported recurrence rates between individual studies. One study reported only 7%, another reported as high as 80%.
80%, that's a massive difference.
It is, and it likely reflects differences in how recurrence was defined, the length of follow-up, maybe the intensity of the sport they returned to, or perhaps how well the rehabilitation and prevention advice was adhered to long-term. But it tells us that recurrence is a definite risk we need to manage expectations about and try to mitigate with ongoing strategies.
Okay, recurrence is a factor. What about actual complications? Are there risks of permanent damage or long-term issues from having had LLS?
Serious complications are, thankfully, rare, given the generally good prognosis. But there are potential long-term issues that have been reported, even if only in isolated cases in the reviewed literature. For example, premature closure of the proximal humeral physis was reported in just 1 participant.
And that's significant because
that growth plate contributes so much to the arm's length. Closing early could theoretically lead to the affected arm being slightly shorter than the other, although the clinical significance in that one reported case wasn't detailed. Other very rare reported issues included accelerated growth of the affected humerus in one case and increased humeral retroversion persisting in 3 participants, potentially related to that adaptive change we discussed.
What about arthritis down the line?
Shoulder arthritis was reported in 7 participants across the studies reviewed. Again, rare, but a potential long-term concern. We also saw reports of other issues like partial tears, pectoralis major, labrum, even UCL tears in the elbow, occurring in some individuals who had LLS.
So other injuries can crop up too.
Yes, and that highlights an important point, the presence of concurrent injuries. Athletes with LLS sometimes also have, or later develop, things like little league elbow, elbow arthritis, other fractures, clavicle, fingers, nerve issues like cubital tunnel syndrome. It really underscores that repetitive, high-intensity throwing places systemic stress on the entire kinetic chain of a young, developing athlete. LLS might be the presenting issue, but it's often a sign of broader overload.
That really broadens the perspective. It's not just an isolated shoulder issue. Connecting this to the bigger picture, it's clearly not just about the physical injury either, is it? Being sidelined, especially for months, must take a toll on these young athletes emotionally and psychologically.
Oh, immensely so. You've hit on a critically important aspect that we as clinicians absolutely must address. The emotional and psychological impact can be profound. For many young athletes, their sport is a huge part of their identity, their social life, their sense of competence and achievement. Being injured and unable to participate can lead to significant frustration, anxiety, dips in self-esteem, and real challenges to their mental health.
That sense of loss, maybe.
Yes, a sense of loss, feeling disconnected from their team, fear about their future in the sport. Imagine that promising pitcher we talked about suddenly. They can't do the one thing they excel at. It can lead to feelings of isolation, and in cases where recovery is prolonged or complicated, even symptoms of anxiety or depression aren't uncommon.
So how can we best support them through this, beyond just managing the physical injury?
This is where the whole support network, parents, coaches, and us as medical professionals become so crucial. We need to provide robust emotional support alongside the physical rehab. This might involve active listening, validating their feelings of frustration or sadness. Sometimes, referral to a sports psychologist can be incredibly helpful, providing them with coping strategies and ways to maintain a positive mindset. Encouraging them to stay connected with the team in other ways, if possible, can help combat social isolation, maybe helping with stats or mentoring younger players. Finding alternative, safe, low-impact physical activities they can do helps maintain fitness and provides an outlet.
Keeping them engaged.
Exactly. And maintaining open, honest communication throughout the recovery process is vital. Giving them regular updates, explaining the process, managing expectations, it helps them feel involved and retain a sense of control, which is so important for their mental well-being. We have to treat the whole person, mind and body.
Absolutely. Okay, let's zoom out one last time to prevention and the bigger picture. How common is LLS in the grand scheme of youth sports, and what are the most important, actionable preventative strategies we should be advising families and coaches on?
LLS primarily affects young male athletes in those overhead sports, especially baseball, and the numbers involved in youth sports are huge. In the U.S. alone, you're looking at around 3 million kids playing youth baseball each year. We know that overuse injuries in general account for a massive chunk of all pediatric sports injuries. Estimates range from 30% up to 50%.
Half of all injuries potentially from overuse.
It's a significant proportion. And focusing on young pitchers specifically, studies have found that up to 74% report experiencing arm pain at some point, and around 23% of those cases seem consistent with overuse injuries like LLS. So yes, it's a widespread problem.
Given that prevalence, prevention is clearly key. What are the top evidence-based strategies we should be promoting?
There are several critical pillars of prevention that we, as medical professionals, should be actively championing. Number 1, proper mechanics and technique. Good coaching that emphasizes correct, efficient throwing form from a young age is paramount, using the whole body, not just the arm. And crucially, discouraging or delaying the introduction of breaking pitches like curveballs or sliders until athletes are skeletally more mature, as these place very high unnatural stresses on the elbow and shoulder.
Okay, mechanics first.
Second, limiting exposure and rigorous monitoring. This means strict adherence to age-appropriate pitch count limits and mandated rest days or periods. Guidelines like those from USA Baseball are a good starting point. But, and this is crucial, we need to educate everyone that these limits must account for all throwing, Not just game pitches, but practice pitches, showcase throwing, playing on multiple teams. It's the total volume of throws that matters. Pitching more than 80 pitches per game or throwing competitively for more than 8 months a year significantly increases risk.
Track everything. Got it.
Third, appropriate strength training and conditioning. A well-rounded program is beneficial. For younger, skeletally immature athletes, say pre-16 or 17, the focus should be on low-weight, high-repetition resistance training to build muscular endurance and foundational strength. Heavy lifting isn't appropriate or necessary. And critically, strengthening the legs and core is essential. Power comes from the ground up, and a strong core helps transfer that force efficiently, reducing the load on the shoulder.
Makes sense. What else?
Fourth, and absolutely vital, emphasizing adequate rest and recovery. This needs to become part of the culture. Encourage athletes to take at least one full season off from their primary throwing sport each year. Allow the body time to fully recover and rebuild. And foster an environment where athletes feel safe reporting fatigue or discomfort before it becomes significant pain. Discourage that push-through-the-pain mentality. Listening to your body is a skill that needs to be taught and valued.
Shifting that culture is tough but essential.
It is. And finally, fifth, community support and education. This is where we have a huge role to play. Proactively educating parents, coaches, league administrators, and the athletes themselves about these prevention strategies, about early warning signs, and about the importance of open communication. Building that awareness and shared responsibility is key to reducing the burden of LLS.
That's a fantastic overview of prevention. It feels like we have a good handle on what LLS is, how to manage it conservatively with good outcomes, and how to try and prevent it. But you've also hinted at areas where our knowledge is incomplete. What are the main limitations in the current research on Little League shoulder?
You're right. Despite the progress, there are significant limitations. The biggest one is the overall quality of the evidence we have to draw upon. Most of the summarized evidence comes from retrospective observational studies, case series, cohort studies looking back in time. These are typically classified as level 3 or level 4 evidence, meaning they are inherently more susceptible to various forms of bias, like selection bias or recall bias. We lack high-level evidence, particularly from prospective studies or randomized controlled trials, which would give us more definitive answers.
So the foundation isn't as solid as we might like.
It's not ideal, no. Another major issue is the heterogeneity across the studies we do have. They often use different criteria for diagnosis, implement slightly different treatment protocols, measure outcomes in different ways, and follow patients for varying lengths of time. This inconsistency makes it really difficult, sometimes impossible, to pool the data effectively through meta-analysis or to draw firm conclusions about which specific approaches are truly superior. We get a general picture, but the fine details lack robust, comparable data.
Right, comparing apples and oranges sometimes. So given these limitations, what are the most critical gaps? What key questions remain unanswered that challenge us in our day-to-day clinical practice?
I think two major deficiencies really stand out. Firstly, as we touched upon earlier, the lack of well-studied, evidence-based coaching modifications and graduated return-to-sport protocols. We know that getting throwing mechanics right and progressing back to throwing gradually are crucial after LLS. We recommend it all the time. But the actual evidence detailing specific effective post-injury coaching interventions or rigorously tested RTT throwing programs is incredibly scarce in the published literature. We need validated protocols.
We need the how-to guide, backed by evidence.
Precisely. Clinicians are often working from general principles rather than proven specifics for this critical rehab phase. Secondly, there's a real paucity of studies with long-term follow-up to truly understand the potential long-term sequelae of LLS. We know symptoms usually resolve, and most return to sport. That's the short to medium-term picture. But what happens 10, 20, 30 years down the line? Is that fizzle widening truly benign in the long run? What's the real lifetime risk of premature arthritis, persistent weakness, or other shoulder problems stemming from that early injury?
Those long-term consequences are largely unknown.
Largely, yes. We have hints from case reports, but no definitive answers. And conducting the necessary perspective, longitudinal studies tracking these kids from injury into adulthood is incredibly challenging, logistically and ethically. But without that long-term data, we can't fully counsel patients on the potential lifetime implications.
So the call for future research is pretty clear.
Very clear. We desperately need more high-quality prospective longitudinal studies designed to develop standardized approaches for diagnosis, for management, and particularly for those graduated return-to-sport protocols.
The ultimate goal has to be generating the robust evidence needed to optimize treatment, minimize recurrence, and ensure the best possible long-term outcomes for these young athletes.
A clear path forward for research. And that brings us towards the end of this deep dive. #tag outro. We've covered a lot of ground today, really digging into Little League shoulder. We started by understanding the specific nature of this growth plate injury, moving through the nuances of diagnosis, seeing how management has evolved towards symptom-guided recovery, and highlighting the excellent outcomes achieved with conservative care. We also stressed the vital importance of prevention through mechanics, load management, rest, and conditioning, while acknowledging the critical knowledge gaps that still exist, particularly around specific rehab protocols and long-term effects. For you, listening as a medical professional, your role is clearly pivotal. Early diagnosis, thorough patient and family education, advocating for that essential rest period, and guiding that careful graduated return to sport, these are all paramount for protecting the health and the sporting future of these young individuals in your care. If you found this deep dive valuable, please do consider rating and sharing the show. It helps us reach more curious minds like yours. And finally, to leave you with something to consider. Given the undeniable impact of intense, repetitive motion on developing bodies and the often immense pressure to perform in youth sports, how can we, as a collective medical community, more effectively influence youth sports programs and culture to truly prioritize long-term health and well-being above short-term competitive success? How do we ensure we're fostering longevity both in sport and in life for our young athletes?